Thank you very much. I have really appreciated being involved. It's pretty unusual, actually, to be able to be involved firsthand with a disorder that is rare like this. And we're learning as we go along. There's no question. Almost every patient I see, I learn something new from the patient. And at the same time, I think I've been fortunate to be in a position to be able to provide input on visual problems to the families. And so it's been a really great two-way street. Now, my background is that I'm originally a neurologist, and then I became an ophthalmologist and combined the two. So I'm a neuro-ophthalmologist. And this type of disorder is like perfectly well suited for someone with my expertise, right? Because as heard from Dr. Mussolino, there are significant neurological problems, but eye manifestations are very common. In fact, sometimes those are the features that lead to the diagnosis. So I'd like to go over I don't have a lot of slides, but I thought I'd go over some of the major features. I know you know the names, but we'll talk about them in a little more detail. And I'd like to acknowledge Ryan Guys, who, interestingly, Ryan worked with me as a high school student, then a college student, then a medical student, and then as a resident, and then he did a fellowship with me, and he's now a pediatric neuro-ophthalmologist at Harvard here. And he and I have seen almost all the patients together. And, you know, I really appreciated his involvement. He's been at this meeting previously, but he wasn't able to. All right, so let's see. I'll go forward here. No disclosures. All right, congenital mydriasis. So let's just, oh, hello. Yeah, congenital. So something you're born with. And mydriasis just means that your pupils are large. You can have large pupils for many different reasons. So there can be a nerve injury that makes the reflex response to constrict the pupil in response to light. A nerve injury could make that response less strong, or it could be a muscle problem. So even though the brain is responding to the light, it can't effect a change in the pupil size because of a muscle problem. I think I have a picture here. Yep. So I'm guessing this is somewhere. Well, you can see. So here we have a pupil that is large, and what you're seeing is what we refer to as a red reflex. So yeah, in fact, you've seen this in cats and dogs at night, right? So when there's a small amount of light and it's dim, you see this reflex, and that's because light is going into the eye and then reflecting back out of the eye. Now, animals like dogs have a special membrane in the back that we don't. It makes that reflection much stronger than typical, and that allows them to see really well at night. We don't have that response, but nonetheless, when the pupil is dilated and you shine light in, there is a return of light, and that's what we see as this red reflex. So what is red in this picture is light that has gone into the eye and come out. Now, as eye doctors, we see this all the time when we use eye drops to dilate the pupils. We see that all the time. But in this condition of congenital mydriasis, where the pupil is naturally large, the same effect occurs, right? So why is the pupil large? So if we did the pupillary light reflexes, you know, the doctor will shine the light in the right eye and then the left eye. The information goes through the optic nerve to the brain. It sees the light and brings it into the brain. And then there's a reflex that says, oh, there's light, and it wants to constrict the pupil. And it does that by sending a nerve impulse back to the eye on a different nerve. So there's a loop, like when the doctor checks your reflexes, right? That's a loop. So here, the nerve impulse does come back to the eye, but the muscle is malfunctioning and can't respond to the light. That's basically what the issue is. So why is the muscle dysfunctioning? That was a really fantastic picture you showed of the muscle not working properly, the mechanical irregularity in the muscle related to the genetic abnormality. I thought that was fantastic. And, you know, how do you think about that? Well, imagine, you know, if you're trying to do work with a screwdriver or a wrench and you don't quite have the right tool. You might be able to get the job done, but you have to work harder to do it. And that's sort of what's happening here. The molecules are not as efficient or effective in being able to cause motion. And so there's less motion, right? And here we see it in the pupil. So just to reflect a little bit on Dr. Mussolino's talk, the iris, the colored part of the eye that we all have, is actually a muscular tissue, and it has pigment in it. And depending upon how much pigment you have or how thick the iris is, your eyes will appear to be blue or green or brown, right? But it's basically a muscular layer. So that's why, and it's a smooth muscle, an involuntary muscle. You can't make your pupils constrict. I mean, if you look at something up close, they will, but you can't say, oh, I want my pupils to be smaller. It's an autonomic muscle, and that's why it's affected in this syndrome. So, you know, all of my patients except one, whom I'll talk about in a little bit, have had drysis, or at least some element of pupillary abnormality. Okay. There we go. So accommodative insufficiency. So those are kind of big words, and let's think a little bit about what it means. The best example is, remember, we don't use cameras like this anymore, but remember, you used to have to manually focus the lens of a camera, right? The same thing happens inside of your own eye. So inside of your eye, there's a lens, and as you look far away or up close, the lens changes in thickness. But what changes the lens? Why does the lens change thickness? Because it's wrapped around by a smooth muscle. So when you look up close, the muscle contracts, squeezes the lens, it thickens it, it becomes a stronger lens and allows you to see up close. So every time we look near and far, that reflex is occurring. That's how we are able to see up close. So this response is called accommodation. All right. So the muscle that wraps around the lens is a smooth muscle. And so there you go. So you can bring an object up close and the eyes will turn in naturally to look up close, but the lens inside of your eye will not be able to focus on it. And hence you'll have blurred vision up close. Now, you know, after the age of 40, most people have to wear glasses. It's kind of the same thing, but for a different reason. You just can't see well up close. You need extra help. The same applies here, even though the mechanism is different. The fact that you can't accommodate is an annoyance, but one that can be treated very easily just with glasses. So it provides the extra strength that you need in the lens to see up close. All right, but from my standpoint in seeing patients, these are the features that I'm looking for. Okay, back to the pupil here for a second. I had these extra pictures. I'm not so sure this provides different information, but it's kind of interesting. So the iris is the color part of the eye, and this is a different kind of way of looking at the iris. So it's like the iris, you're looking at it now on the side, and there's a pigment layer in the back, but much of the thickness of that iris is from the muscle. All right, now, in children, actually for any system in the brain, the development of the brain, the building of these myelin pathways, and the building of all the synapses that link the brain together, the way we build those systems is by experience. You know, as little kids begin to play, and when they're very young, they reach for something that kind of really clumsy, and a couple of weeks later, they're a lot better at it. That's just because you're building these pathways in real time based upon experience, right? The same kind of thing happens in the visual system. Your ability to develop high quality vision, which by the way, doesn't happen for years. So a young baby might have something like 2200 or 2100 vision. They can see your face, but it's pretty blurry. But, you know, a few months later, there's more detail in your face, but you don't actually reach the full level of adult visual acuity until about age 3 or 4. So part of that is experience. The more you do, every time you send a new piece of information to the brain, it's making little changes in its wiring in order to ultimately provide you with high-level vision. So the point is, if there's anything that disrupts the quality of the visual image that the brain receives, then the brain can't do its job. It can't build all the little connections that it needs to give you the best vision if it's not receiving good vision. You might think of it like glasses. Like, I see you're perfectly fine. If I take my glasses off, I can still see you. You just don't look nearly as good, right? So if that's the information the brain gets, it can't build the infrastructure to provide you with high resolution vision. So we call this amblyopia. Amblyopia is a situation where the brain just isn't able to build the information. It requires high quality input, and then it can use that to build the infrastructure. So with respect to accommodative insufficiency, a baby's vision should be perfectly fine in the distance. But most of what we do in life is kind of up close. And so if you're out of focus perpetually up close, it can degrade the level of vision that you ultimately will have. Right. So that's why we often use correction, sometimes in young kids, to provide the best level of vision that we can. All right. Now, Dr. Mussolino mentioned this earlier. Of course, we've talked a lot about blood vessels. When I was a neurologist, I was always interested in vision. And, you know, you've heard this phrase, everyone says it. The eyes are the window to the body or window to the brain. And it's pretty amazing. I mean, by doing an eye exam, you can often tell whether someone has high blood pressure or diabetes or many other problems, because the back of the eye is lined by the retina. The retina is the nerve tissue in the back of the eye. Think of it as the film in a camera, or now a CCD chip in a camera. It's the structure that basically takes the pictures. That retina is actually a part of the brain that during development grows out of the skull so it can see light. But it is a part of the brain. And it's connected to the visual part of the brain, which is back here, by way of the optic nerve and other tissues. So vision begins in the front, but it's the back that allows you to understand what you're seeing. So here we are looking at the retina, which is a part of the brain, and the retina has blood vessels, both arteries and veins, and you get a sense for what they look like here, right? This is the optic nerve head. So all of the nerve tissue from the entire eye, think of it like a big antenna. All of those nerve fibers go across the retina and then make a turn to form the optic nerve that connects the eye to the brain. And this is the optic nerve head. Inside of that little structure, it's 1.5 millimeters. Inside of that little structure is over 1 million nerve fibers, just to give you a sense of the nerve tissue. And in each retina of a human, it's about 150 million nerve cells in each retina for humans. It's a part of the brain. So it processes images just like the brain does. Like you say, the brain does your thinking. Well, the thinking for vision begins in the retina, and then it stops at a certain point. That information is sent to the brain where more processing is done. Well, here we are being able to look at the blood vessels of the retina, and what has been clear for many patients with ACTA2 is that the tortuosity that is commonly seen in the brain blood vessels is also present in the eye. And it is, in some respects, a biomarker. It's harder we can't see the blood vessels in the brain when you can do the angiograms that Dr. Mussolino showed you, and they're fantastic. But as ophthalmologists, we can see much smaller blood vessels. And if we use special techniques to image those blood vessels, then we can see down to the individual capillaries in the retina. So you can't do that in the brain. So we can not only use the blood vessels as a biomarker for how much tortuosity there might be in the brain, but we can also assess blood flow in a part of the brain by looking at the retina. So, in a disease like this, there's so many things that the doctors and researchers would want to do, genetically, medically, treatment-wise, so many things. We've often talked about wanting to use artificial intelligence to look at these images of the retina, to digitize them, to look at the images of the brain, to digitize them, and then to do the comparison, to look at the correlation between the two. The appearance of the blood vessels in the eye, we think, will be predictive of what might ultimately happen in the brain. By the way, these blood vessels are really interesting. I don't know whether you've heard this story, but Google, all the things it does with all the data that it has from all of us, 4 or 5 years ago, they published this amazing story with, deep learning. So they fed, I don't know how many, 50,000, 100,000 images, fundus images to the Google computers and asked them to, well, what can you figure out? It was able to distinguish a man from a woman, something we have never even thought of. But the computer just doing what it does, it just looked at the way the blood vessels are, and it had a database of whose pictures it was. And the output was, well, yeah, we can see a difference between a man and a woman. No idea how. I mean, as a doctor, there's no way to do that. So there is information buried here that we would like to unravel to help us understand this particular Act 2 problem, but also it might help inform us about other problems as well. All right, so I mentioned to you about the blood vessels in the back of the eye. Dr. Mussolino, you saw images of a CTA or an MRA. She also mentioned that you could have a catheter angiogram where they put a catheter in your bloodstream, bring it up to the brain, inject dye. That's how we used to do them all the time. In the retina, we do something similar. So those are the blood vessels on the top. And to look at the blood flow pattern, not just where the blood vessels are, but how much blood is getting through them, we can inject a dye in the arm called fluorescein. And we do a fluorescein angiogram, and it's a video. So we can watch the blood flow going into the arteries and then coming back out of the veins. It's pretty cool. But more recently, there's a different technique. That's what this is here. This is called an OCTA. The A stands for angiogram. So maybe 25 or 30 years ago, at MIT, right across the river, a researcher there was developing a new imaging technique. He wanted to study the skin to see if by imaging the skin, you could, for instance, find tumors, melanomas, and other things. And almost immediately it was recognized, well, why look through the skin? We could use the same thing and look at the eye. And it completely revolutionized imaging of the eye. OCT is a standard technique. I probably used it 10 times this morning with my patients. Standard technique. And what's amazing here, you can see the larger blood vessels, but these little dots that you're seeing are capillaries. And amazingly, you get these images without having to inject dye. In a few seconds, you can image the capillary network of the retina, something you could never do in the brain. And so we have not in any way looked systematically at OCTA yet for Act 2, but it's an opportunity, I think, going forward to try to look. It'll presumably, the hypothesis would be that we'd begin to see abnormalities in blood flow in these very tiny blood vessels before we see abnormalities in flow in the bigger blood vessels, which would be great. All right, so you've heard the term vascular tortuosity, and that basically means the vessels are wiggly. Now, there are a lot of people in this room who may have wiggly blood vessels. It's not in and of itself problematic. But when they're quite wiggly, more wiggly than normal, it raises the question of whether there's an abnormality. And in Act 2, that's quite common. And this probably doesn't project very well, but these veins here are bigger than normal and just have a little more wiggle to them than most. It's something that a doctor looking at the back of the eye can very easily recognize. All right, so there is another unusual disorder. It's a detail we probably don't need to go into, but the iris, the colored part of the eye, provides the opening, which is the pupil. Directly behind the pupil is the lens that I was talking about before. And one of the conditions that's involved here is a vascular blood vessels forming on the lens. That never happens. You don't want to have things on your lens. It's like, right? It's like having a dirty windshield. You don't want to have things growing on the structure that you're trying to look through. But in this condition, presumably because there's impaired blood flow in general, and when there's impaired blood flow, the body often tries to make new blood vessels to get blood in. And in doing so, it creates blood vessels on the surface of the lens that normally would not be there. All right, so I'll end with a story. I just had an opportunity to see a patient recently. She said it was okay for me to say hello. It was actually an amazing story to me because, as you know, when patients come in and, I try to be chatty and I tell the residents, I said, it's kind of a method to my madness. It's like if you don't just do the medical thing, if you just try to talk and form a relationship, all sorts of information comes out that otherwise wouldn't happen if you were just, you have a 10-minute conversation. It's all about medicine. There's a lot of other stuff you don't learn. So I didn't know the diagnosis when you came into the room, but as I said, so why are you here to see me? And you said you had an ACTA2 mutation. And I'm saying to myself, wow, like I've seen a fair number of patients, but I've not seen someone who walks in and looks like you do, right? So as I'm talking to her, I'm realizing her pupils aren't dilated, right? And as I do the rest of the examination, I'm saying, wow, like I'm not seeing any of these things. It's an amazing story because, and I think I mostly have this correct, but there were many members of Cheryl's family, going back to your grandmother, many members who had and died early from thoracic aortic dissections, aneurysms. That was well known. In fact, it caught the attention of a major researcher at Hopkins who defined the syndrome. It was Dr. Dietz. He defined this syndrome, Louise Dietz syndrome. And he anticipated that that would be the diagnosis. So the family came in and they were studied. It wasn't the right diagnosis. And I don't have these details down exactly, but that was a couple of decades ago. And then there was a researcher here, Dr. Stoller, who heard about the family, and additional testing was done to rule out other disorders. They were negative. But then she learned about the ACTA2 mutation, contacted the family, and they were tested. It was positive. So this kind of thing in medicine happens frequently, where there's a medical problem that is beyond our level of understanding, right? And so we begin to see patients and we try to help, but we know we don't know what's going on really until you do. Some new discovery allows you to understand what's happening, and then you could be more helpful, of course. So now Cheryl has a different mutation than the typical one, like the 179 that Dr. Mussolini was talking about. And so, one has to interpret this in a way that that mutation is allowing the muscle, the molecules to move more effectively than would occur in the 179 mutation. And so you don't have tortuous blood vessels and other factors, right? So the point is, there's a spectrum of disease. And whenever there's a genetic mutation that you can identify, it is a fantastic opportunity to understand what's going on. And with different mutations, there are going to be different clinical manifestations. We call that a phenotype. The genotype, the kind of gene abnormality, the phenotype, what it presents with medically. And so, just having a chance to meet you just reaffirmed my my understanding that I have a lot more to learn about this. And I think as we see more and more patients, we'll be in a better position to understand and ultimately to help. So that's all I had to say. I'd be happy to answer any questions either now, I don't know what the timing is here, or just outside.
So the answer.
Wait. So I could, why don't I step outside and I'll be happy to answer any questions if you'd like. Yeah.
I was about to say, yeah, right now we're going on a break.
Oh, perfect.
So yeah.
Yeah.
He's going to be outside. If anybody has any questions, please, again, he's making himself available. If you don't get a chance to speak to him before you leave the conference.
Yeah, we can connect later. Yeah.
Correct.
Good.
Yes.
Thank you very much.
Thank you.